And so the chair that we have right now is, I don't know if it can support the bulk that is currently on top of it.
If you eat
So
shit, there's no way I'm cutting that. It'll be a true test of central stability and motor control.
I'm gonna, you know, I am an athlete, so the extreme amount of athleticism that may be on display this morning might come to fruition for everybody listening and watching. So,
how is the new house, man?
We moved January 1.
Oh, so you're not in it yet?
We're not in it yet, but very, very excited. It's so much better than what we're in right now, renting and stuff. And
yeah,
we knew the place we're in right now, we knew was going to kind of be a transition house until we get to something we want.
Mm-hmm.
So almost get my wish like you know, to be able to walk out the back and do the thing and
do your thing,
but like there's houses around, but how we're situated is like, if we're standing like right against our house, nobody can see the backyard.
See, which again, it's a little colder here, but now that the leaves are off the trees, I may be pushing it. So I wait for spring to come back before I can do that.
We need a little bit more foliage on the branches before we start to.
So that's how I gauge my wishes now. I'm like full year-round access to that.
Yes.
Well, how's it? So how long have you been at Parker now? You guys been down there for what, 3?
May of 2018 is when I started.
Oh, okay.
And so, and MaryAnne started in January of 2019. So over 2.5 years.
How's that been? How's it going from private practice to academia?
It's good. It's very different. Obviously, they both have its pros and cons. And if it was ever possible to kind of like have like an amalgamation of both, like being able to benefit from those, then it would be like the perfect scenario. But very different than private practice, obviously. A lot of aspects miss quite a bit from private practice, but there's also a lot of aspects in teaching that you'll never get in private practice. Well, I wouldn't say you never get, but it takes a lot to get there. Basically, you're just like running the business essentially, right? And not really practicing to be able to do some of the things you're able to do in private practice. So
yeah, what's we'll get into that a little bit later. Obviously there's private practice challenges, right? Maybe not so much like the actual practice part, but like running a business and stuff. What personally, and then also with like the students, I want to explore both of these. Like, what are some of your challenges being in that setting for you? And then I'm going to ask, I want you to know the follow-up. What are some of the challenges with students, like of what you're trying to accomplish with them, or just challenges in general? So what's like a personal challenge in that setting for you?
Personal challenge in the teaching setting?
Yeah.
I think there's a lot about that you miss from the patient interaction and being able to being able to think through a problem and a process, be able to not solve it, but like almost like kind of digest a mystery and be able to help them out on the back end of that. So one thing I've tried to do with that is be able to try, how do I transition that into the classroom? You know what I mean? Because the students come to me and try 6. Before they get to me, they're from a biomechanics standpoint, they've had one biomechanics course, which is mostly motion palpation, but they go over quite a bit of biomechanics. But there's so much time that lapses over from try 2 to try 6. It's like, and sometimes when they come to me, it's like, well, they don't remember all of it. You know what I mean? So trying to catch them up to speed. And I feel like I kind of, where I want them to be at the end of my class, PT2, which is all the active therapeutic exercise, where I want them to be at the end of my class, I have to like really kind of not catch them up, but like there's a lot of background stuff that I need to give them, and obviously there's still some stuff from boards that they still need to know and that type of stuff. So I think the challenge for me in the clinic and the classroom aspect is getting them to understand the things that they need to know for boards, but really how to integrate some of the stuff that they need to know for boards, but really how do they integrate all this other stuff into actual practice, which they're not going to get to start doing in like 2 more trimesters.
Mm.
You know what I mean? So there's this like there's a big gap, I feel, leading up to and then after the course for my material specifically.
Mm.
Right. And then
that seems like the big desert with students right now overall, right? Like it doesn't matter what part of education you're in, try 2, try 10, or practicing still, it's like and again, it's probably what you said is really what people are getting at, is the problem solving aspect is when you're actually putting your clinical skills into kind of critical thinking and doing that in a timely manner. But that's what everybody's missing. So I know MaryAnne and I have talked about that, and like that's kind of the critical piece. So like, do you have any examples of like how you do incorporate that into what you're doing?
I do. And it's ironically, it's actually not in my course necessarily. It's in another course. So they have a currently the students have a class called full spine adjusting, which is kind of like what we did at Logan in Tri 6, where we had 10 weeks where we assessed and we adjust our partner before leading up in the clinic and student clinic in Tri 7. Well, there's no student clinic at Parker. So Tri 8, you're in outpatient clinic. And then Tri 8 treat internal patients, which are students. They treat students for however long. There's certain requirements you have to meet before you're released to see external patients. And they could typically start seeing external patients with up about 4 weeks or so after they start Tri 8 to try and get their numbers and whatnot. And so Tri 5, 6, and 7, they have a course called FSA. So it's full spine adjusting. So it's FSA 1, 2, and 3. And when I get the students in FSA 3, I get maybe anywhere from 1 to 2 to 3 classes, depending on how large the class is. And there are groups of 10. That's actually the class that I'm able to pull things together for them, because the FSA itself isn't necessarily structured to have any context around what you're doing. It's just, hey, you have to have 9 adjustments, 3 in each region, by the end of the semester, and so go. And so like when I first started doing that class, it's like they're coming to me with like, okay, they're doing a full spine workup. They're not supposed to have any pain. The patient is, so to speak, their partner, right? That's not supposed to have any pain. And I'm looking at this and like, okay, they do the workup, and there's like these listings is like, okay, C1, 2, 3, C5, 6, 7, T1 through T12. They have all these malpositions and restrictions and stuff. I'm like, what are you going to adjust? You're not going to adjust you're not going to adjust like 20 things. Pick 2. And so like I try to create a little context around that. So, okay. So I started creating parameters. And so I kind of know what, for the students, that is, so I kind of know what the docs in the clinic want in terms of a time aspect of they wanting to work through a patient and paperwork. So I try and get them as like, okay, day 1, here's the deal. The faster you realize you're not very good at this, the better we're off. Okay. So get yourself in a mental state of, I want both you and your partner to be done assessing each other in the next 15 minutes. And there's 2 hours for that class. Right. And so they do that. And they're like, oh my God, I can't do this. And then, and then like two weeks later, they're both done in 15 minutes, because nobody ever challenges them. They're not going to get there. Right. And so then I start saying, okay, well, right now, mentally, you have to put yourself, there's this patient that doesn't have any pain. What if your patient comes in, or you have a patient comes in, it just wants they want a performance, or they heard the benefits of chiropractic, whatever they come into you with, right? What are you going to do? And they're like, stone face, like, well, they don't have pain. I don't know. Like, okay, well, assess them. Like, what if they don't have pain? They're like, well, how do I do that? I was like, do you not remember functional assessment? Like, how about you have them touch their toes? How about you extend back? How about you have them squat? Right. And so you see them moving in these global patterns, just like a basic, almost like a top tier SFMA. Where are they not moving from? Are they moving too much from some areas? that's what's going to lead you to your quick scan, your MPI stuff. And then you can get into your specific palpation things. It's an assessment funnel, right? And they're like, well, that makes sense. I'm like, I know we've given you the pieces, but it's up to you to try and like put them together before we get there. Right. And so when they started doing that, they're kind of seeing like, okay, well, I'm always finding this C5, these C4s and C5s as the students present. I'm like, don't, it's a trap. Don't do it. Leave it alone. And because they'll have another listing of like, upper cervical or like CT junction. I'm like, hey, I'll tell you what, adjust this and then repalpate. And like every time they're like adjusting, they're like, it's gone. I'm like, I know, magic. Right. And so like, trying to create context around those things and like get them to like, oh, you find lumbar restriction. How about you do some bird dogs here or do some side planks or something like that? Or how about you just like do this isometric lifter's wedge into the strap and see if that changes. And of course it changes, right? It's because they've never seen the effects of exercise on a patient necessarily, right? They've only, in the clinic, usually they only get adjusting, or they get like passive modalities, unless they've been through, when I was previously in the clinic before transitioning over into the academics, unless they had me as their doc, they never saw the benefits of doing, mixing in therapeutic exercises along with manual therapies. Right. And so trying to create context in that course is actually an opportunity, I think, that I've tried to like, take and like move forward a little bit so they could kind of at least start thinking like, oh, I took this, PT2 and functional assessment. I don't know how to use it, although we go over how to use it in the class. But they don't see it in action necessarily one-on-one because the time's limited in those courses. There's a lot of content we need to cover, obviously. So trying to implement some of those things in that course is kind of where I think, we can start kind of bridging the gap a little bit from the academic side over to like, now you can use it in practice, so to speak, but then transition to clinic and keep using it, please.
Yeah. Well, I think the other side of, what's being sought is kind of the polar opposite of at least what I've seen. So you have, kids that don't know how to integrate anything at all. And then there's, and I say kids, students that have taken every, post-grad seminar while they're in school. And all of a sudden I've heard kids say, man, I don't think I should be doing, I'm air quoting chiropractic. Like I'm, I can do everything hands off. It's exercise, pain science, pain neuroscience. And it's like, and I mean, I had one student literally like reach out to me and be like, I think I should drop out. Like, this is ridiculous. I should just be, a coach. And I was like, well, there's a lot of levels to that. So I think you're obviously seeing the academic, like they're learning the bare bones skills, and it's very, I don't want to say foundational, but chiropractic's at the center of what their treatment is, right? It's the exploration that maybe isn't there yet, even though it may happen in a couple tries or a few years. What would you say to the students on that other side that are kind of seeing a loss of value in manual therapy and things like that because they're just being maybe inundated with all the other information?
It's funny is because going through school, I didn't take any continuing education at all. I didn't really know. The only continuing education I did really was I read, going through my back surgery stuff, having to do my rehab after my fusion. I read McGill's book probably about 4 or 5 times through try 6. And then the Liebenson's book, the same amount. Right. And so that was like, to me, that kind of like that stuff, like really like spoke to me from a rehab standpoint. And so that was like the only continuing education I ever had, really got, until after chiropractic school. Then I started taking seminars and stuff. And so I kind of hit that point a little bit in like maybe year 1.5, close to 2. I wasn't to the point to where I was like, I shouldn't be in chiropractic. I did get to a point to where like, there's a lot more that I can do that I don't need the manual therapy aspect of it. There's a lot that I can do. But then it was like, I think there was a realization of like, hey, again, it's like, it's almost like when you're going from like pure manual therapy to exercise, right? It's like, well, I have manual therapy. Why do I need anything else? You start learning all this exercise stuff and you're like, oh, well, there's a big benefit to this, but the pendulum starts to swing too far over here, right? It's like, oh, there's all this exercise stuff. Why do I need manual therapy? it needs to start swinging back to the middle. Right. And so I think the, the next patient that like came through my door after I started saying, I was like, oh, I don't need a lot of manual therapy stuff. I could just do a lot with this exercise, was a big manual therapy case right square in the forehead. And that was the benefit of clinical practice, is like, you're going to get that exposure often, and then you start to realize like, well, I need all these tools. These are all tools. You know what I mean? I need all these tools to be able to start implementing for the patient in front of me. That whole N equals one thing. You never know when you're going to use X, right? I used to always say, I'll never use clamshells ever. I'll never use clamshells. This is why. So I was try 8. We had advanced biomechanics with Winchester, right? And I was having this weird case in biofreeze, and I'm doing some glute stuff with this patient. He was like, well, what are you doing for glute stuff? And like, the only thing I knew at that time, I was like clamshells. He was like kind of scoffed. So, I was like, and I kind of looked, he's like, well, I could think of quite a few more exercises that are better than clamshells. And I didn't know. Right. And I was like, well, what? And he kind of gave me some exercises. And I was like, I looked up and obviously they're better than clamshells, And so from then on, I was like, oh, I'll never use clamshells. And then I had in practice, I had a case come through where this older lady, she clearly had like severe foraminal stenosis, to the point to where the musculature wasn't firing at all in her hip. And like, she had a bunch of bone spurs shaved down. And so it was like, literally, it was like impinging on the nerve root. Right. And so there was no glute. She couldn't do anything. I was like, let's start with clamshells. And then it worked great for her. Right. And like, obviously it didn't, like, that one session didn't build her up to where like, oh, I can stand on one leg now. But like, she started to feel like the glute firing. And she was actually able to start moving the leg. And then I was like, insert foot in mouth, never say never, right? Because you never know when you're going to have to pull out that thing.
And I think probably the best point out of that is maybe students, what either, way the pendulum's swinging for them at the time. It's like, and I tell all of our, whether it's, undergrad interns or, externs, like, don't set your paradigm too early. As soon as you close your mind down, then you start going that way. And I think we all do that. You kind of maybe go this way for a little bit, and then as long as you divert, but if you kind of go too far one way, all of a sudden you're going to run into that case that humbles you, or you don't help that person, or you get put into the scenario at a super high level. Like, say, everybody uses the example, but a pro athlete comes in and you're not able to help them because you don't have, whatever you need. And that's where, again, then you're like, man, I wish I would have done more. But again, it gets tough because then students now, and the next question for you, I just feel like it's massively different. Like, I did a lot of seminars in school, but like, even though I did a lot, it's like this month I'm doing a small amount versus a huge amount of what students do now. And it's almost like they feel like obligatory, like they got to do it, to be good. And it's like, what are your thoughts on that? Because like, I think it can be dangerous. It can, obviously it's awesome, but it's obviously also individual. Like, some people can't do it, some can, but like, what are your thoughts on that?
I think it depends. There's a couple of factors. I think it depends on what the student did before chiropractic school. So if they had a background in massage therapy and or exercise, like strength and conditioning, maybe they did, they had to have a legitimate kinesiology background where they had to do legitimate, research and stuff like that. I think those students could probably they could take a few seminars. I'd probably wait till like mid chiropractic school, like try 4, try 5, maybe. I think students coming out of undergrad like myself that were biology majors, because we didn't have kinesiology at my undergrad, I was in from a mental standpoint, I was in no shape to like take a DNS. I had no shape to take like a McGill. I'd have been, over my head. I feel like it would have been, knowing my athleticism now, looking back on it, I'm just kidding. But but honestly, like, some students shouldn't be taking things until like try 6, try 8, try 9. Some students like myself, like I think I probably could have took something like later on, like try 8, try 9, and I would have been able to grasp it and know where it kind of like goes down my, like my treatment methods, but some students don't have a science background at all, and there's a lot you have to learn to be able to apply some of this stuff and not just in clinic, but obviously in practice, right? When you're maybe 2 years out of practice, some students are in try 3, they don't have a background in kinesiology. They don't know what biomechanics is. Literally, they don't know what that, what it is. And I don't have a biomechanics background. You just kind of learn it as you go, right? They go to like a DNS or they go to, even a Liebenson, first personal movement, start talking about BPS and stuff, and it's going to be over their head. It's just going to be over the head. Now, do they need to hear it? Yeah, I think they need to learn it 100%. I think they need to be exposed to it, but I think it would be overwhelming to some students that early on in their education, if they don't have the background, if they don't have like something like a massage therapy, or if they don't have like a specifically a strength and conditioning background or experience coaching,
So this brings up an interesting point, and you're a good person to speak on it. And I know there's probably a bit of things that you have to toe the line on what you talk about, but like, that being said, like I went to business school, right? I worked for a while, then I came back, but I was always involved in athletics. So it's not like that's like a, in place kinesiology degree, but when you're involved in it, I think you understand your body better, which allows you to have a little bit, better insight. Maybe it's not a degree, but do you think that students should be required prior to entrance to have either experience, right? Like you need to have done something, right? I'm not saying like be a trainer, be a strength conditioning coach. Like your degree should be, general science realm's cool, but like if it had some component that if there were, I'm just going to say, if there were more stringent admittance qualifications or, strictures that it's like, man, we need you to do something like an internship before you come. Like all the UAB students here have to do an internship if they're a kinesiology major. A lot of them come here, they may still go to PT school, but they have to do something before they actually get admitted. Right. And I think that's just good because a lot of them change their mind. Like, oh, I don't 100%. Want to do this, or I want to do this thing. So what do you think about that?
I think, yes, I do. Obviously that's not a part of the thing we kind of look at to allow students in necessarily as an internship. But I think I'm on the admissions committee, so I do have to kind of keep an eye on. But I think having something, I think having a couple aspects. I think having an internship like that would be huge. I actually, like I mentioned earlier, I was biology, but it was pre-physical therapy was the degree. So I had to do a semester at a PT's office. And so that kind of, it was exactly what I thought it would be. It didn't change my mind of what I wanted to do. I did go to chiropractic school instead of going to PT school, which I kind of planned on, but that was from another conversation with somebody else. Right. But I think having that internship is pretty important because like you said, you don't know that you don't want to do something until you start doing it. That's a big part of it, right? You need the exposure. I also think an interview, an actual physical interview or like a virtual interview face-to-face is really important in admitting everybody. I do. Like, I think, there's, I tell this, and you can't really get this when you just do an interview, but like I tell the students when they come to me for Try 6, because my course is pretty tough. It is tough, but I ask a lot out of them, and I want them to be good. The status quo is terrible. In this profession, it's awful, right? And so I tell them that, and I tell them, I said, hey, we're here as a profession. I want you guys to be here. I want you all the way up here. Right. And so I, try and do the things to bring them all up, you know what I mean? But I think having a better idea of who's coming in, as opposed to, okay, you have a 3.0 plus GPA in the sciences, you have minimum 90 hours of science stuff. Okay. I think there needs to be more. But
And that's,
hey,
yeah, and it does get tough. And I mean, I know we did. So when I went into Logan, we did an interview. And again, I'm air quoting. That interview was just with the admissions officer. It wasn't
right.
with anybody from the faculty. It wasn't in front
Yeah.
of a review board. And
Mm-hmm.
just even if the level of scrutiny from that board isn't super high, like I'm not going to say you're just doing it because you're doing it, but just having a student sit in front of a group of faculty, which is eventually going to be colleagues and peers, change the game versus you just sitting down with an admissions advisor where it's kind of just like, yeah, we're just making sure you're not a criminal or, whatever. And that doesn't change the game, but it starts to change your mindset from day one of like, stepping up your game and like, oh, I felt like an idiot in front of that board. Well, you don't know anything yet, but like you should immediately want to change that. We've touched on some of this stuff with like the seminars and stuff. You being around, you're in a different school, so I know that is part of it, but then you're around, a different generation of students now. What's one or two of the biggest differences that you notice just in like chiropractic school education or the students right now versus when you were in school?
I feel like we had more coursework, like a lot more coursework. I feel like we had, because we were upwards of like 40 plus hours a semester.
Mm-hmm.
We got into like try 7, I think it was try 6 or try 7. We were like 45, 47 hours or something crazy like that. I think the one thing I think we benefited from Logan, multiple things obviously, but like one big thing was we continued to have classes in the clinic. So try 8 and try 9, we had courses, and we had once you get to try 8 at Parker, it's it. You're just in clinic. And so I feel like the lack of having actual coursework and actual and classroom learning, I think you benefit a lot from that, and be able to maybe apply that directly to your patients like day one. It's almost like kind of like we go to seminars now, and like we learn something like, oh my gosh, that patient, I can use that for that patient. And then you go and try it, right? That's where now it's like these students have to go to club and try and learn something from club. And like, okay, can I apply this to my patient here, as opposed to learning from your faculty? And it's like, hey, this case presentation presents like this. If you do this exercise or you do this intervention and you get these responses, try this, as opposed to like maybe in the clinic. And this is, the student fumbles with something with a patient. Not all of them have the gusto to go to their clinical faculty doctor and say, hey, this didn't work. And it's like, why wouldn't you consult with the person who's managing? A, it's their patient, right? Yeah. But B, like consult with the person who's like helping you in your education. Yeah, and not all of them do that. And so I think there's a big gap there. And from the transition over the clinic aspect that we actually had at Logan, I think it was very beneficial. And I feel, I think the exposure of one thing I think was positive with Logan too is the exposure to the different things. So we got exposed to diagnosis periodically throughout our education. As we're Parker, it's like a diagnosing class. Differential class was exposure over a couple semesters. One semester it's differential, right? Here at Parker. And so like, and even like biomechanics or honestly just kind of like exercise stuff, right? Mm-hmm. We had at Logan, we had hard biomechanics, which was good to learn. And then a couple semesters later, we had like PT2, mm-hmm. PT1, PT2, you're getting some exposure there. And then all of a sudden in Tri 8, you had like the best course at Logan was advanced biomechanics with Winchester.
Doesn't exist anymore, which is sad.
So, what? Are you serious?
Yeah. So Winchester's on a leave of absence. For a lot of reasons, but yeah, that course isn't there, which
Oh, wow.
Just saying that is, when you're like, take away the best course. And it's like, especially with what you're saying, which is I think an awesome point, because a student who's in clinic that's still having to educate themselves exactly what you're going to do when you're in practice. Hopefully you don't go into practice and you're just like, I'm just going to get those cheap CEUs at the end of the year and fill them. No, you like literally you want to be learning all the time. And that may be reading, it may be talking to a colleague. It doesn't have to be a seminar. It could be like literally I have a hard case. Do you have a group or a person to reach out to talk about that? And you're learning and not being, hide in the shadows and I just kind of screwed up. Well, I'm kind of going to just, bury my head in the sand.
I think too, one thing I feel, again, I wasn't around all the students in my class, so I don't know if this is just something that myself and like my friends did in my class, but I feel like we asked a lot of questions to our doctors at Logan. Like we asked about cases, we asked, specific questions. We tried to get them to help us work through cases and stuff like that. Maybe that was a product of the environment as well, being around BioFreeze a little bit too, where they kind of encourage some of that stuff. But even leading up to that, I feel like we asked a lot of questions as to where, occasionally you'll get a student who asks quite a bit of questions, but for the most part, they're relatively quiet. And I don't know if that's, and I don't know if that's a thing where they're just kind of, they're nervous about asking questions or what, but I think, being a student, you have to understand, like immediately, we go over the Dunning-Kruger effect, like day one in PT2, right? You have to realize that you don't know anything. So ask questions, you know what I mean? Honestly, there's no stupid questions. There really aren't, right? Because that always leads to, if you have a question that, people are worried about it being a very low level question, you know what I mean? Well, I can expand on a low level question and blow the top off your head. You know what I mean? But why this basic principle applies to this concept that's like way over here, so I can bring it home. You don't have to worry about it being a stupid question. It's just ask, and I feel like at Logan, we did that. And again, I don't know if that's just kind of like a, generational thing or what, but I feel, the ability to ask questions is kind of,
well, and
not as.
Sloan and I are always telling, I feel like we're old timey people when we're like, oh, when we went to school, when we're talking to interns or new docs, but like, I always go back, even though there were definitely aspects that looking back weren't good, but like our BioFreeze experience was completely influential on how I practice because you got challenged. Not only,
oh my gosh,
it's kind of like it was the scenario that you think you wouldn't want to ask questions in, right? Because you knew if you asked a question, you weren't necessarily going to get an answer. You were going to get challenged to try to think of the answer on your own, which I think is really what you're doing when you're in practice by yourself. But you could also end up getting your head bit off, or they call a group around and now you're all of a sudden demoing or trying to explain what you just asked, which again, that's what you're doing to a patient. So
yeah,
I think about that all the time, and it's not like
it made you comfortable with being uncomfortable.
Yeah, and that's what I don't think happens a lot, because you're going to be uncomfortable so many times in practice of you don't know what's going on, you don't mesh well with somebody, it doesn't go well. Like you think you know what's going on, they just don't get better, and you're all these things make you uncomfortable. So okay, so if that's a thing that you see with students, like what would you suggest to them? Like I know it'd just be like, hey, open your mouth, but like they have club, where hopefully that's an environment.
Yeah. That I think that specifically, I actually kind of try and incorporate that into my course, my actual PT2 course. So I do a thing that's called kind of off topic, but kind of bring it back to feeling uncomfortable. I do a thing called we do a thing called skills checks. And basically when I get them to coach an exercise, I want them to follow the coaching communication loop that Winkleman talks about. So you describe, you demo, you cue, they do it, then you debrief. So you basically try and change the movement if you need to, right? And so I want them to be able to check off those 5 check boxes, right? And we have to, and it just has to flow. This is patient interaction essentially, right? And so they mentally have to put themselves in a place where they have to imagine this person in front of them has no idea what you're getting ready to ask them to do. Even though that person obviously has studied the material that you're getting ready, that your guys are practicing, right? You put yourself in that position. And I leading up to practicals, like and it's one-on-one. We're in a group setting, but the communication's one-on-one. When I give them feedback, it's not like I'm pointing out to everybody their mistakes, right? I'm brutally honest. I'm like, does that make any sense? You know? And they're like, what do you mean? You just told them to do this when we want them to do this, you know? And they're like, oh, and like, they kind of start seeing like, because the language they use is like doctor language. You know, they don't need to know what a gluteus maximus is, right? Just say glutes. You know, this is going to work the glutes here, whatever. Okay. And so a lot of them respond well to that type of like interaction, and some people don't respond well at all. And so like for me as a coach, right, communication, I have to kind of like position myself differently and use different language, inflection of voice, right, different communication, you know, with those individuals, those students, to try and get them to like kind of continue to buy in and use the stuff that I'm trying to grill them on, right?
Yeah.
And I tell them, I said, look, this is patient care. This is stuff you're going to do in practice. It's going to feel uncomfortable. You're going to feel silly doing some of this stuff, but this is just real life. You know what I mean? And so I think that getting that exposure in other classes, maybe, or like kind of like being put in situations, you know what I mean? Changing the variables, you know, taking, you know, in that FSA 3 lab, sometimes what I'll do, it'll be dead quiet. And sometimes I'll throw on like, you know, Frozen 2 soundtrack super loud on my phone just to kind of distract them a little bit before they're getting ready to adjust. So you have no idea what's going to happen in practice, right? You have to be ready and focused and dialed in, you know what I mean? So we start adding variability there at the end of that course to try and create situational things, you know, and I think for me, being in the academic side, purely academics now, trying to find opportunities to expose them to being uncomfortable, to try and create a robust doctor, so to speak, is pretty, and, you know, try and find as many as I can, but I'm kind of limited in time, you know?
Yeah.
And unfortunately, you know, being in the clinic, which I was, you know, what I did when I first went to Parker, being in the clinic, a lot of docs have trouble with that because they're still trying, you know, not because they're incompetent. It's because sometimes they're still trying to get the student to get an appropriate soap note at the end of try 8, you know. It's like, why am I having to allocate my time to you writing a soap note? This is where your differential diagnosis goes in the differential diagnosis box, you know, not in your orthopedic test box.
Yeah.
You know, they're having to put out other fires and stuff, and unfortunately it's kind of, you know.
But that's what a lot of students feel like a big part of their education is just kind of like learning like the puppeteering part of like, oh, you got to do this is what you do, you got to know this for boards. Like it's very much, it's concrete of like, this is what you need, but at the same time, like it's not actually what you want to have to be a good doctor, right? It's kind of like, you know, you get here and then it's like, ooh, you're kind of on your own. And like Winchester said something that was pretty clever, because it's pretty sad that you got to spend $200,000 on your education. You still have to go to a club to be a good doctor. And it's like, a lot of students feel like that. I'm not saying that's the truth, but a lot of students feel like that. So one thing that I kind of always go back to is like, I think in school or out of school, like I think there should be a like clinical debate group or class where you literally, the whole goal of the class, it's not necessarily to argue, but if you go to like a medical conference, they're extremely comfortable with like arguing. Like somebody brings up research, like this doesn't make sense. Like, you know, we go to conferences, seminars, if somebody asks a question, it doesn't get shut down, but it's very much like, well, we're here learning this is why we do this. And then the conversation kind of stops at that explanation. Or same thing if it's, you know, like two docs talking, it's like, well, I do this, because there is a lot of variety in our profession. Like, how do you think you can foster? And again, we've been talking about like suggestions, like what would, you know, like we all practice different, even if it's similar, like you and I, very similar, but we would look at a case and still treat it different, right? It would look kind of the same, but it's different. It's like, how do we, again, get students and doctors to be comfortable with like, I mean, how many times you see on Facebook, somebody brings up a case and all of a sudden it goes from really good dialogue to an argument. And you're like, can't we learn rather than just like, you know, tear it down? It's like, how do we help like foster that kind of a I don't even know what you want to call that, like a mindset or an environment or whatever?
I
Yeah,
think,
big question.
yeah, I think the gift and the curse is, is just the profession in general. Um, the type of people that the profession attracts,
Mhm.
um, that has a lot to do with it, I think. Um, and I think being exposed to specific continuing education and how they communicate and how they deliver information is actually kind of important in the beginning. If they take that earlier in chiropractic school, because that attitude gets translated over into their communication about specific topics, and
That's a good.
being willing to like learn and be patient and try and instead of being reactionary, process things, and think of different contexts when one person might say this implementation of X um can typically do this, and like if like it's sparks this like anger in you, like be
Mm.
patient, think about it, like is there a context when you might apply their X intervention to X condition or patient or situation, right? And if those two people would actually have a conversation, more than likely they would come to an agreement if they're able to say stuff. It's things like over Facebook and social media, essentially, right? Having conversations through typing it's almost impossible to get across, like to actually truly
Yeah.
communicate exactly what you're trying to say and what you mean. And I think if we're more patient with before we press, Herm Edwards, says, don't press send. you know, he says a couple of things. He's like, hey, nothing good happens after midnight, and don't press send, right? And so, like, if you really take your time, don't type it out on the response, the comment section, type it out on Word, right, on an unsaved document. And if you don't think the context is going to come across appropriate, just delete it. And if you really want to talk to this person about X topics, send them a private message like, hey, I was going to respond, but I kind of, I don't think it's going to come across appropriately. Would you mind like setting up a video chat to kind of talk about the specific topic? That's something like that. I think would probably solve a lot of like, it would get rid of a lot of BS on social media.
Mm.
But I think, for me, like I usually don't, I try not, I don't comment very much at all. It's because, your context is never going to come across appropriately.
Yeah.
It just won't. So,
That's you kind of say how like people get very, I don't know if angry is the right word, but it's kind of just like territorial with like information and like
very defensive.
yeah.
It's just almost like you're challenging their knowledge
And I think
of a specific topic
yeah, I think where that comes from is the whole profession is like an iceberg, and then it's like we broke that iceberg into a million, and you're just standing on your little piece of ice because everybody's different. It's like if that gets challenged, all of a sudden your livelihood's like, yeah. And it's like, dude, rather than trying to make, rejoin all those little icebergs together, it's like I'm just going to stay here and not try to actually like join with people. And it's not like, and I also think you feel like you're giving up something, right? If you're like, oh, that is, it's like, oh, that person like, is right and they got one over on me, because you're talking to patients all day. And I
right.
think you get this mindset that like you're the authority. If what I think's wrong, all of a sudden like it's almost like a imposter syndrome, like, oh shit, I don't know what I'm talking about. But like
Yep.
that goes back to what you said earlier of like, you better be comfortable with like not knowing anything, being humble continually, and just like that's your life.
Right. you're just going to get stomped on repeatedly, right? And how you manage that and how you respond and react to that is just so important. And a lot of people respond to stress by shutting down,
Mm-hmm.
and the patients see that. And I think that's some of the, when I was in a clinic, that was one thing I was actually able to do from a management standpoint of the interns, is be able to expose them to that, not necessarily in front of a patient, but like one-on-one to them, right? And
Mm-hmm.
so you gotta challenge them. You know what I mean? So okay, you have these three differential diagnoses here. What test are you going to do for so the patient has low back pain. So what tests are you going to do? What diagnosis in low back is Hawkins Kennedy going to help with? And they're like what? Oh, that's a shoulder. Let
me go through my clinical process real quick. Oh yeah, I'll get back to you. Yeah.
Oh yeah.
That's I just think it's interesting because obviously we went to school together. We were, a little bit apart, and then we were both in private practice at the same time. And then you going into academia, and it's just, we're in multiple professions have options, right? What you can do, like the options are endless, but then like, just like the best athletes in the world, right? Like they look like they don't get bothered by getting crushed every day, but they're getting crushed every day in some way, and they're opening themselves up to
100%.
But then it's like they're reacting, but they're not like overtly reacting like, oh my God, like this destroys me. It's like you react, you learn, and then you keep moving. So like what you athlete, like,
they seek.
I was just going to say, like, you feel like kids or students, I keep saying kids, students need more things outside of school to put themselves in that scenario. Mm-hmm. Like it's more a character building and like personal building rather than like what you're actually doing in school, maybe.
Mm-hmm. Yeah. I mean, I think those, like you said, you're kind of using the athlete analogy. They actually seek out, they want to know, they don't just want to know what they can do to get better. They want to know, they almost want to get ripped apart, because that helps them truly process where they need to make that, divert most of their efforts towards, you know what I mean? And I think having the going through the BioFreeze internship, it really, it was not for everybody. No. And it was, it was not for everybody. And a lot of people who did it, they realized quickly that it was not for them. But I think, obviously they stuck with it. I think they, whether they would like to admit it or not, they came out a much different and more whole student getting ready to start practice. Mm-hmm. And I think, and I'm kind of weird though. I loved it.
Yeah, I did too.
I loved it. And it was because it was so challenging to me, and it was challenging, and it made me like put my head down and work. But I mean, that's just kind of, I guess that's the kind of person I am. Like my style of work is just like stress, respond to stress. You know what I mean? And I think if you're going to do really well in practice legally, I think responding to stress is something that if you can get really good at that, that'd be really, 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 really important.
And I know a lot of people wouldn't agree with me. I kind of dreaded football practice every day a little bit, because you just knew it was going to suck. Right? Like some part of it, conditioning, something you're not very good at, somebody's going to rip into you, you're going to be put on the spot, like whatever it is, like some part of it sucks.
Conditioning for me, 100%.
Yeah, but then you also like that, like gets me like riled up of like, oh, I can't believe, and then that's like building. But yeah.
And the next thing you know, practice is over. You blink, the practice is over. You had no idea. It wasn't so miserable,
That's like type 2 fun. You get done, you're like, oh, practice was so fun today. And it was
cool. Yeah, it was awful. Everybody's dying, and you're like,
But yeah, BioFreeze was definitely transformative, and for what we did. And I don't want to necessarily say I want to recreate that for our externs and students, because I think there were definitely parts that I think
there's aspects of that need to be done.
Yeah, 100%.
100%. Some aspects don't necessarily.
Which were personal, things. Yeah. Outside of that, it was great. And I just think that's, I'm not in academia, so I can't say I think that's what's missing in, the education now, but like I can definitely see a difference in students that come in now, not necessarily like intelligence and bare bones knowledge, way ahead of where I was, but the confidence to fail on the fly and then learn is like low. And I think it's just because of the situational awareness of like not putting yourself there and knowing like that's normal. Like you're gonna fail.
Yeah. I mean, it's almost like is some of that missing from like further back
life
before life like before chiropractic school, right? It's like was there a disconnect somewhere along the line there, be it be a like sports background or, you know, or just obviously other factors too, you know, like family stuff too. So I mean, I'm sure there's more factors to that. And I think, you know, in terms of like, you know, for me being in academics, you know, trying to create really, really good doctors, keyword doctors. I think there's a lot of stress that needs to be placed on the students to try and create positive change. Because if you don't place any stress on it, obviously they're not going to change. It's the product that's going to come out is not what you want, right? It may make for a better student, but it's not going to make for a better doctor. And they're very different. It's a very, very different. I don't want to graduate students. I want to graduate doctors, right? And so I think having that that thought process and that frame of mind of being able to create stress, but also not being so stressful to where you're not allowing adaptation to create. And it's just super weird. I'm using like a strength and conditioning analogy, but you know,
it makes sense
for making doctors, but it's the same, right? You know, if you go too hard on them and you don't like back off a little bit and allow them to like process where they failed and be able to change, you know, then you won't create that change. But also if you know you're constantly bending and you're constantly allowing them to kind of, you know, do whatever they need to do to like move along, then you're accruing, you know, colleagues who are not able to pay their student loans.
I think so. It's kind of a good point, right? Like what you learn in school about the human body can be applied, which is, you know, nerdy as that sounds, like the physiology demands that we know, whether it's Wolff's Law or, you know, exercise physiology, like that applies to you as a human, and you have to do the
said principle.
Yeah. Like do those things. And, you know, I mean, there's a reason that, you know, medical sales companies want athletes. There's a reason that insurance companies want, like, that. There's a reason, right? So like, I'm not saying that like, you know, chiropractic school and PT school has a plethora of athletes for a lot of reasons, right? It's a movement-based profession and all those things. But I think it really goes back to, if we had to put a bow on this, you know, podcast of like the person that's coming into chiropractic school. Yeah. But yeah.
A bow.
The person, like, not, you know, I'm saying the person, the character of the person coming in, and like their ability to do that is maybe what's needs to be discerned more, rather than like, what was your GPA? Those things are important.
Like, but the communication skills are so important, right? And even though most of us are gonna be in private practice alone, right? The ability to communicate is so important. I think, you know, the true team aspect of it, if you're able to play team sports, being able to communicate to multiple people is going to help you through school quite a bit. But B, if you start to have, you start to have an office manager, or you have another doc come in your practice, being able to communicate to them and, you know, be able to like communicate together, not just you talking at them, is super important. And I think, you know, a lot, and that's not, of course, this is not across the board, but a lot of students who don't have that sports background, or they don't have some type of background in, like, maybe they were really active in student senate or something like that, going through like high school and college and stuff. It doesn't have to be athletics, but something where they have to communicate with other people, and like see a process of things, following a process, sticking with a process, that type of stuff. I think they typically struggle quite a bit coming out of school.
Yeah, that's a good point, because maybe, you know, we were talking about like a debate course or team or whatever, you know, like clinical debating, but what if it's just literally like clinical communication? Like, that's not a course, right? Like, why are we know how important the therapeutic partnership is, buy-in with the patient, all, like, and why is that not, you know, we talk about it, yeah, for sure, but it's not really worked on.
That's one thing. Being able to work on it is, you know, and that's what I think, you know, the one thing would be good for Parker is to kind of add something like that, to be able to actually work on it. You know, my wife is much better than I am at everything. But she does that in her functional assessment. I think she does it in a lot though in nutrition though. And she actually has them work on it in her nutrition course, because our nutrition was like just facts essentially, right? But like what it should be is like some facts, obviously, but how do you take a nutritional history? Like what questions do you ask, you know, like what recommendations do you make? And she has them do a ton of projects on those, of actually asking people these questions and doing these things, right? Making these recommendations. So like the actual application of what you're trying to learn. And so I think she does a really good job at that, integrating that into her course itself. But you know, if you look at it across the board, typically courses are like, you know, and this is every chiropractic school. It's like, it's this course. And this is the class. Okay. And this is this class, and this is this class, and this is this class. When they come to try 6 to get PT2, we're like, oh yeah, this is PT2. Guess what it incorporates? Everything, right? You know, I'll throw, you know, mechanism of injuries into questions, throw orthopedic tests into questions, differential diagnosis into questions, you know, functional assessment into questions. And they're like, well, this isn't exercise. We're like, well, it's patient care.
Yeah.
And guess what you're going to do in patient care? You'll probably use exercise. Guess what else you're going to do? You'll probably use an assessment, use an orthopedic test, use XYZ, imaging findings, whatever it is, right? But you have to be able to pull that stuff in and be able to like process that and use it. That's being a doctor. It's not being good at PT2. Right. It's not being good at orthopedics. It's being a doctor, being able to take all this information and apply it.
And I think that's probably the best way to wrap up, because I think a lot of students, they probably know that, right? Like, oh, I got to integrate the stuff and be able to critically think. But I think they get a little bit like subdued into the thought that if I just learn everything, whatever comes at me, I'll be okay. Just because the encyclopedias, you've read all of them, does not mean you know how to like go get the fact, put it into practice and do it. And like, I mean, I tell the story all the time. Like Winchester told me, like, don't do any seminars. Like I had done a bunch already, and he's like, stop. He's like, don't do it. He's like, start learning how to integrate this stuff, and you'll be better for it. And I'm not saying to don't do that stuff, but like, again, I could memorize every fact in the world and still be a terrible physician and get, you know, perfect scores on boards and everything.
Yeah. And I think I actually did pretty good through chiropractic school from a grade standpoint, but even like getting into clinic, I think one thing that I was pretty good at in clinic was communication. Well, getting patients in, communicating with patients, being able to talk to them. It was easy for me because I'm usually a pretty quiet individual. But no, I'm not. I talk too much. But, you know, I think the thing where I even had a disconnect of like, because I remember sitting down with Dr. Engelson, and she asked me, I think it was just a part of what Logan had to do. And she asked me a question of like, you know, give me some differential diagnosis of like, you know, knee pain. And, you know, one would think of like simple things of like, you know, patellar tendonitis, IT band syndrome, you know, but like I kind of froze, and I was like, the only thing I could think about was like these super complicated, like zebra things. Right. And I was like, blah, blah, blah. She was like, yeah, okay. But what about, but like understanding that, and that, I think, you know, having that conversation probably it opened up my eyes of like, this is what they mean. Don't chase a zebra. Like just use logic, use your brain. And that's what you should be doing as a student. That's what you should be doing with your doctor in clinic, is sitting down. Like if you don't quite grasp how specific courses or classes kind of mold into being a doctor, because that's what you should be learning how to do is from head to toe, treat everything. I mean, not head to toe in the body, but paperwork, taking the history, note taking, like what frame of mind you should have when you're taking a history, asking open-ended questions and funneling down to like more specific questions, how all that's information, taking this and apply it to your, you know, your differentials, and then go into your testing and stuff like that. That's what you learn in clinic. You know what I mean? But if you don't grasp that and you understand that you've already learned all this stuff in class, now you're taking everything and you're kind of pulling it together. I think that, you know, as a student, if you're not doing that, then that's on you.
Yeah.
100% of that's on you. You're not, you know, this is your opportunity to ask questions and fail a lot.
Yeah.
With obviously the supervision of your doctor. Right.
Yeah.
But this is your opportunity, you know what I mean? Fail now so we can coach you and help you. And that's why when you get to practice, hopefully you don't fail as bad. You're going to fail. Yeah. But hopefully you don't fail, you know, don't do anything crazy.
You don't want to fail big. You don't want to feel big, right? You don't want to hurt someone.
Right.
Your practice.
Exactly. Yeah.
You don't want to not be able to feed yourself. Like that's failing of not getting one person out of back pain and learning like, oh, that won't happen to me again, or I'm going to try to at least not let it happen. Like that's a good fail.
Like, oh man, I didn't teach this person how to, like, how to hip hinge, or like how to sit in a car, or how to, how to get it up and down in the chair. Like, that'll never happen again. Right.
Maybe that'll be the title of this podcast. Fail good, fail real good.
How to fail good. How to fail gooder than everybody else.
Well, tons of great info. And again, I don't know who all listens to this podcast. Probably just my mom. But beyond that, hopefully students listen to this thing and like apply some of this stuff, but also like, hopefully it creates dialogue, right? Within classrooms, within groups, with, if you're thinking about going to school, or if you're new into practice, like if say you're out on an island, you're in private practice by yourself, and you're in an area that doesn't have anybody that's really like-minded, well, you better get a group of people, or at least one other person, because if you're going to have stress and need to be able to adapt, like you said, you probably need somebody to throw things off of, or at least decompress. I think that's the biggest thing is, realizing that the stress repair cycle is not just physiologic, it's also personal level too.
100%.
Well, cool. I appreciate you being on here so much, Cody. And
thanks, Beau.
I'll put any contact info you're comfortable with putting, I'll put that in the show notes. So if anybody has questions for you, any last pieces of sage wisdom from Dimak before we get off here?
There's never too much coffee.
It's true, as long as the toilet is near. So
not a TP shortage. So.
Well, I'll let you get off to this morning. And again, thank you so much, man. I appreciate it.
Thank you, man. Appreciate it.
Later.